De lujo. Ahorita que vean ustedes sus antecedentes, su especialidad y el impacto que tiene su trabajo sobre un problema tan grave como hemos tenido ya muchas décadas, que es el cáncer. La doctora Sophie Lebel es doctora en psicología, es investigadora, es decir, encabeza proyectos de investigación, es profesora titular de la Facultad de Psicología de la Universidad de Ottawa en Canadá. Tiene más de 80 publicaciones en revistas arbitradas e indizadas. Tiene más de 200 ponencias en congresos especializados sobre sobrevivencia del cáncer, temas de estigma por el cáncer, miedo a la recurrencia del cáncer, sexualidad y fatiga también relacionada con el cáncer. Ha desarrollado y validado sistemas de medición sobre el miedo a la recurrencia, ha creado medidas de miedo a la recurrencia del cáncer y examinado el impacto de este miedo sobre la utilización de servicios de salud y de recursos en salud. Ha realizado estudios cuantitativos y cualitativos de este miedo en una gran cantidad de grupos de cáncer. Desarrolló un sistema de terapia cognitivo-conductual de 6 semanas de duración, muy peculiar, sometido a prueba mediante 2 estudios aleatorizados controlados. La terapia la llama FORT, originalmente en inglés y en francés, ahora está en español. Se ha evaluado en ensayos controlados. Ha recibido varios premios por su trabajo. Creó un grupo de interés especial sobre miedo a la recurrencia de cáncer en una de las más importantes sociedades internacionales que se dedican a examinar el cáncer, que es la IPOS. Trabaja con nuestra colega que no veo aquí. Ya la vi. Ya la vi. Quien es tutora de nuestro posgrado en medicina conductual en el Instituto de Cancerología. La doctora Lizeth Galvez está adaptando y va a someter a prueba el efecto del sistema IPOS y del sistema FORT que desarrolló la doctora Lebel. Y entonces, además como psicóloga clínica, trabaja con pacientes con cáncer en todas las etapas de la enfermedad, desde el diagnóstico hasta cuidados paliativos. Utiliza la terapia cognitivo-conductual y la terapia existencial para ayudarles a manejar su miedo a la recurrencia de cáncer. De modo que hoy nos va a hablar sobre el rol de la psicología en la atención del cáncer y el miedo a la recurrencia de cáncer. Y como ven, quedamos en excelentes manos, de modo que les pido que me ayuden a darle una gran bienvenida.
Gracias. Por la introducción. Hola, buenas tardes. Gracias a todos por estar aquí, a las personas que están aquí en persona y a las personas que están en línea. Intentaré hacer esa presentación en parte en español, pero el español es mi tercera lenguaje. Mi primera lengua es francés, después estudié inglés y ahora estoy estudiando un poco de español. Y mi español en verdad está mejorando. ¿Okay? Aquí está el resumen de mi presentación. Hablaré sobre mi educación y mi trabajo con pacientes de cáncer. Centraré la mayor parte de la presentación en el miedo de la recurrencia. Y tendremos tiempo para preguntas en español, por favor, o en inglés al final. Yo tengo 3 objetivos de aprendizaje para ustedes. Quiero explicarles lo que es la psicooncología, mi subespecialidad, y también la prevalencia y el impacto del miedo a la recurrencia. Y quiero darles algunas herramientas para trabajar con los pacientes que tienen este miedo. Empezamos con un poco sobre mí. Ahí están algunos de mis estudiantes a la Universidad de Ottawa, en nuestro campus. Tengo 2 mascotas que me gustan mucho y mi familia y el famoso invierno canadiense. Sobre mi educación, hice mi licenciatura a la Universidad McGill en Montreal y después mi doctorado también en Montreal, a la Universidad de Montreal, sobre los supervivientes del cáncer de mama. Fue una de las primeras investigaciones de los supervivientes del cáncer de mama en Canadá. Después me mudé a Toronto para completar mi fellowship. No sé cómo se dice esta palabra en grande especialidad, mi fellowship, en un hospital oncológico que se llama Princess Margaret Cancer Center. Para nosotros en Canadá, el Princess Margaret Cancer Center es como el INCAN. Aquí en México es el más grande hospital oncológico de nuestro país. Y después de mi doctorado, tuve que ser supervisada durante 1 año y completar 3 exámenes para devenir psicóloga. Se necesita mucho tiempo para devenir psicóloga en Canadá. Y después de todo mi estudio, finalmente encontré un trabajo como profesora universitaria en la Universidad de Ottawa hace ya 15 años. Pero, pero todavía soy estudiante este trimestre y también el próximo trimestre a la UNAM en Gatineau, cerca de Ottawa. Tenemos un pequeño UNAM donde pueden aprender inglés, francés o español. Y estoy haciendo un curso de conversación intermedio en español que es muy útil para este viaje. La verdad es que no estoy un muy buen estudiante, pero I am trying. Oh, my goodness.
They feel the same they do.
Oh, about English.
Psychology students.
Oh, my goodness. Okay. What's okay. Bon.
You need help?
Yes. No. Okay. No. No. Okay. Gracias a la doctora Elisa Galvez por la invitación. Tuve el placer de conocer a la doctora Galvez en un congreso en Banff, Canadá, hace 3 años. Mi último congreso antes de la pandemia. Y la doctora Galvez vino a visitarme a la universidad en Ottawa en septiembre, durante su sabática. Y ahora yo estoy en sabática y me toca estar aquí para ayudar a formar los psicólogos en el uso de la intervención FORT sobre el miedo a la recurrencia, adaptada a la cultura mexicana. Ok, bien, quiero hablar un poco de mi trabajo con pacientes de cáncer. Ustedes saben que cada año hay más de 18 millones de nuevos casos de cáncer sobre todo el mundo. Y en México, como en otras partes del mundo, muchos pacientes de cáncer viven más tiempo y se consideran supervivientes del cáncer. En México hay como 500,000 de supervivientes cada año. Y este creciente número de pacientes con cáncer llevó a la creación de un tipo de psicología de la salud llamado psicooncología. Y es esto que somos la doctora Galvez y los psicooncológicos. La psicooncología empezó en Nueva York hace 45 años y se encontró Sí. Encontrar. Mi conjugación de los verbos es un poco difícil. Se encuentra en muchos países ahora. Okay. Y bueno, ¿qué es la psicooncología? Es una subespecialidad multidisciplinar de la oncología que se ocupa de los pacientes, de sus familias y también del personal de salud. Y la segunda parte es que es el estudio de las variables psicológicas, sociales y de comportamiento que influyen a la prevención, el riesgo y la supervivencia del cáncer. Ok, los psicólogos tienen un rol importante dentro de la psicología. Como psicólogos trabajamos en centros oncológicos, hospitales, clínicas privadas, instituciones académicas, como yo. Atendemos a pacientes a todas las fases de la enfermedad. Mis investigaciones tratan sobre la fase que se llama supervivencia, pero como psicóloga en mi oficina yo trabajo con pacientes en todas las fases y todo tipo de cáncer, porque a veces algunos psicólogos se especializan en una población, como por ejemplo adultos jóvenes o mujeres con cáncer de mama. Y la verdad es que nosotros psicólogos vemos a algunos de los pacientes más angustiados o más difíciles. ¿Y en qué ayudamos? Porque las pacientes con cáncer tienen muchos problemas. Hay muchos problemas con los que podemos ayudar a los pacientes. Y una forma de clasificar todos estos problemas es un modelo llamado marco de necesidades de apoyo. Es de una profesora de Canadá que se llama Margaret. Este modelo habla de necesidades físicas, espirituales, sociales, psicológicas, etc. Y en Canadá y también en los Estados Unidos, en Europa, las pacientes tienen más problemas que se llaman psicológicas. Y lo que es importante que saber es que entre todas estas necesidades psicológicas, la más importante es el miedo a la recurrencia. Y también la doctora Galvez hizo una investigación sobre las necesidades de apoyo aquí en México con casi 400 pacientes con cáncer de mama. Y el miedo a la recurrencia es el problema número 1 de estos pacientes también aquí en México. La próxima diapositiva te va a gustar. Change language, lo siento. Ahora voy a hablar de, del miedo a la recurrencia y esto es un poco difícil para mi español intermedio. So voy a hablar en inglés, pero todas mis diapositivas están en español y puedo explicar casi todo en español, ¿ok? Y la verdad es que me gustaría si haya preguntas en español. Estoy aquí para una inmersión total. Okay. Definition. I will speak slowly also. Like people speak to me slowly in Spanish, I will speak slowly so everyone can follow me. If something is not clear, please raise your hand and I will try to explain. And like Doctora Galvez has agreed to be my translator if we need a translator. Okay, so here's the definition of fear of cancer recurrence. Miedo, preocupación o inquietud relacionados con la posibilidad de que el cáncer vuelva o progrese. It is what we call unmet need or necesidad insatisfecha. It's the most frequent one. What is an unmet need? So when we ask patients, what are some of your problems? We also ask them, what do you want help with? And what is it that we have not helped you with? So you have this problem. Sometimes patients have something like pain, your area of specialty, but they said, I have pain, but it's okay. My doctor is helping me, I'm okay. But fear of cancer recurrence, they say, I have fear of cancer recurrence, but nobody has helped me with this. I want help. You might think, well, maybe fear of cancer recurrence goes away with time. With time, we get more relaxed. We don't have this fear. It's not true. So this is the point here. Solo uno de 21 estudios encontró que este miedo disminuyó con el tiempo. So what happens is patients have the fear early and it doesn't go away. And why is it important to study this? Okay, so there's cost to the medical system. We studied, as was mentioned in the introduction, what happens for patients with the most fear of cancer recurrence. And we found in a study that these patients go back to the emergency room, emergencia, right? They go back to the emergency room more often. They also take more medication, and they ask to see their oncologist more often. So this costs our public healthcare system, also in Canada, more money. Of course, they have things like menor calidad de vida and una reducción del funcionamiento social. So it will impact their day-to-day life. I work with many young patients who are of working age. It's not time to retire. They're in their 40s, but they're not sure if they want to go back to work because they're scared. And they tell me, this is going to be too much stress if I go back to my job. I'm not sure. So this is a decrease in their functioning because they're scared. Of course, this is associated with distress, that was translated as malestar psicológico. So distress. The more fear you have, of course, the more distress you have. Now, maybe you wonder, okay, this is probably true, but how often does this happen, this fear? Something maybe like 10%, 20%? It's a lot more than that. So we have, I was part of a team that looked at 87 studies. We grouped the data of 87 studies, 13 countries, and more than 11,000 patients. And everybody was using the same instrument to measure fear of cancer recurrence, all these studies. And what we found is almost 60% of patients had clinical or very high levels of fear of cancer recurrence. So these are the patients that you, as therapists, psychologists, would be asked to see. So it's a very high percentage. Over time, the study found that fear did not decrease, so it didn't matter. It wasn't important how long ago they were diagnosed. They still had the fear. Important to know, limitation, there are very few studies being conducted in what we call developing countries. So there were no studies from Africa or South America, for example, in this review. As far as I know, in Mexico, the only study that has been done is by Dr. Galvez, who has now studied this need. Maybe some of you have worked before with what we call the care providers, or what we call here cuidadores familiares, the caregivers. It could be the mothers, it could be sisters, it could be husbands, children that take care of the patient. Those cuidadores also have fear of cancer recurrence. They worry. They worry that the cancer is going to come back for the patient. We did another systematic review, and we found that the fear is as frequent in the cuidadores that it is in the patients. So when you work with patients, it's important sometimes to also work with the families, because they also experience fear of cancer recurrence. Okay, I've been talking about fear of cancer recurrence, and I've mentioned miedo clínico a couple of times. What is miedo clínico? Fear goes from little fear, moderate fear, high fear. Low fear is sometimes, it was often men with prostate cancer, and they told me, no, I don't worry about this. Okay. Then we have some patients who are like, I think about it once or twice a year when I have to go back to the oncology center. It's okay, it's difficult for 2 weeks, but I'm okay. This is moderate. Clinical fear of cancer recurrence, the patients that I help, it's different. They're different in a few different ways. So they have high levels of preoccupation, altos niveles de preocupación, altos niveles de ansiedad. Okay, so they are often also, so they have high levels of these thoughts. What's different with these patients is persistentes. They worry not twice a year, they worry several times a week, or cada día. Okay, they worry almost all the time about this. So their preoccupation, their thoughts, when they start, it's not just something that goes. They think about it sometimes for hours. Okay, they think, it's like, I cannot get rid of it. The thought is here. Some people say, is this a Spanish expression? El diablo en mi espalda. We say this, the devil on my shoulder in English and in French also. So it's always like a little something that's here on your shoulder talking to you. That's how they talk about their fear. Also, those patients that I work with, those patients with clinical fear, has what I call here hipervigilancia or hipersensibilidad a los síntomas corporales. So we all have headaches, or sometimes, this hurts or this hurts. It's normal. But when this happens to them, they think, oh, mi cabeza. I have a progression in my brain. I have metastases in my brain. The cancer has returned. But there's no evidence of this, but they worry immediately, oh, it means that the cancer has come back. So they're often checking bodies and feeling things. So they have this high level of being very vigilant. And this has to be present here at the end, un mínimo de 3 meses. And we have to see a deterioration in the functioning. We came up with this definition by interviewing and doing surveys, que se llama Estudio Delphi, with 65 experts on fear of cancer recurrence. So this is what we use to investigate, to know if somebody has clinical level. And I want to talk about Jorge's master's thesis. Can you say? Jorge Bastan is one of Lisette's, Dr. Galvez's student, and I was the examinador. Mm-hmm. It was a muy buena experiencia para mí porque estaba en español and I could follow. I was very proud of myself. It was an excellent thesis. So what Jorge did is qualitative interviews of 10 Mexican women with breast cancer treated here in the Incan Institute. I want to show you, there's so much to talk about. It was so interesting because there are cultural differences between Canadian women and Mexican women that we talked a lot about. But I want to show you a few narrativos. I don't know if you can see very well, okay? I will read some because it's not very clear. So the women chose a name. It's to show you what fear of cancer recurrence looks like and the words of the patients. Because sometimes when I'm learning something new in psychology, I want to know, what do the patients say about this? So the first person se llama Luna. She's going to talk about what it is like to finish treatment, because that's a difficult time for patients. Okay, excuse my poor Spanish. Pues, un digo que bueno, porque ya, ¿cómo te diré? A veces siento que la quimioterapia me protegía del cáncer. Por ejemplo, ahorita que no la tengo, me hace pensar, ¿y si regresé? Como si la quimioterapia fuera algo que, a pesar de que te daña, te está protegiendo. So she thinks that when she's receiving chemotherapy, she's okay. But eventually, the treatment stops. And now she thinks, what is going to happen to me? This we see also a lot in our Canadian patients. When they finish treatment, for us in Canada also, what's different, they go back, the oncology center says, okay, we're done. Now you go with your family physician or general healthcare provider. So this is a difficult time for many of our patients. The second woman talks about her emotions. So what kind of emotions do people have when it comes to fear of cancer recurrence? She chose Mariela. Pues lo que más siento es miedo, tristeza. So often people talk about being sad, sometimes about being angry, panicking, being very afraid. Sobre todo, por la que ya había platicando. No quiero que mis hijos sufrían si me vuelve a dar cáncer. This is very important. We found this in all the 10 narrativos that we did together. The women were really worried about what is going to happen with my family. We see this also in Canadian breast cancer patients, but this was maybe something particular to Mexican culture, the importance of family. So for them, they were really worried about what is going to happen to my family. And what was interesting is that it was difficult to talk to the family also. So we're going to talk about this later. And the last person, I chose this one, her name is Anita, because she talks about what it's like to go back to the cancer center, how scared she gets. Te siguen revisando de un pasillo y donde tú dices, ay, estoy bien y nada más me están dando seguimiento. Y de repente me hablan en el pasillo donde están todos los oncólogos. Y she says, ya me van a dar una mala noticia. She says, I don't feel good. They are going to tell me bad news when I come back to the hospital. Our patients in Canada also think the same. They are really scared when they have to come back for these exams. So this is what the women are saying about their fear here. Okay. Who are the people who are going to experience these fears? So some people, as I said, have little fear. Some people have high fear. Women, okay? Women are more likely to report high levels of these fear. Pacientes más jóvenes. So for me, a young patient is somebody under the age of 50. That's what I call a young patient. It's strange to have cancer when you're 40 years old, 30 years old. You have young children. You have many things. So it's difficult for those young patients. Also, the patients that have multiple physical symptoms or secondary effects. Because there's many things that are hurting them in their body, and they think, oh, maybe this is the cancer that has come back. And the 10 interviews that Jorge did, women often talked about feeling a pain in their breast. They said, oh, I have this pain in my breast. I think it means the cancer has come back. Also, the last one is the risk, perceived risk of recurrence. And these patients know sometimes what the oncologist has told them. So stage 2 or early stage breast cancer in Canada, the risk is maybe 10-15% that there will be a regression. Okay, so it's not very high. But when I talk to the women and I say, do you know what your risk of recurrence is? They say, yes. They call me Sophie, or Dr. Sophie. They say, yes, I know what the oncologist has said, but I don't believe this. What I believe is that my risk is 100%. Okay, so they know what the medical doctors are saying, but they don't think this is true for them. They are saying it's going to happen. I don't know when, but it will happen. So of course they're scared because it's a certainty for them. Okay, preguntas? We're okay so far? Okay. All right, what do we know about culture? Because a lot of the work I've mentioned so far has been done in Western countries. So I was lucky to be part of another systematic review. I do a lot of systematic reviews, eh? I was lucky to be part of a systematic review that said, what about culture? Right? Well, we know it's important, but what happens? So I was part of an Australian team that looked at fear of cancer occurrence in indigenous people and what we call minority people. So minority people are people that are that don't identify with the majority culture, so white culture, and 4 countries in this study: Australia, Canada, United States, England. There were 19 studies, and in general what we found is that there's more fear in indigenous people and in minority people. And of all the minority peoples, the most fear was found in people that identify as Latino, Latina. Interesting. These are studies from the United States, okay? And they found many reasons. I don't know what you think right now, because I saw some of you, oh, interesting. What they found in the United States is there's cultural beliefs. What a cultural belief called fatalismo, okay? They said maybe this doesn't help. Stigma, taboo, and the community about cancer. And that in the United States, they have private healthcare mostly. So many of these immigrants might be poor and not able to afford some of the treatments. It costs sometimes hundreds of thousands of dollars if you don't have insurance in the United States. So this increases their fear because now you're really scared. This is going to cost you a lot of money if you get sick again. And some of the immigrants might have lower levels of education, so they don't understand everything that's happening to them in the healthcare system. Lack of knowledge, so se llama conocimiento sobre el cáncer. Okay? Lack of knowledge is something important. That might be one of the reasons, and something I want you to remember from my talk today. There is something that everyone can do as psychologists or other people that help cancer patients, is help them get more information. In Canada, this happens too, but we found that the women that were interviewed by Jorge and Dr. Galvez, they were really lacking some information about the hospital about the treatments, what causes cancer, what causes recurrence. So this seems to be contributing to why Latinos have maybe higher fear. What's clear also is that in these people, more fear, lower quality of life, more angustia, menor calidad de vida. We looked also at some qualitative studies. What's different in these culturally different? Spirituality. In Canada, nada habla de su religión. It's something private. It's something private that you don't talk with your psychologist. I don't talk about it. Sometimes if a patient talks about their religion, we'll talk. But I will not ask. So nobody really talks about their religion. Difficulties, complications with the support from your family. I mentioned that in Jorge's interviews, many women said, oh, I don't talk with my family because why, you think? Why do you think they don't want to talk with their family? Yes, to not worry them, exactly. And the family doesn't want to talk with the patient for the same reason. They don't want to worry. So I'm worried, you're worried, but we're not going to talk. Also, there's stigma or taboo in the community, so it's difficult. Your biggest support is your family or your community, but you feel like you can't talk, so you feel alone. There was a lot of themes of solitude in those 10 narrativos. Again, there was also la importancia de mantenerse positiva for these patients a lot. And as I said, not knowing enough about a cancer, lack of knowledge. Okay, so with this, now I want to move. We're going to talk about la terapia forte. Okay, what is it? So it's a combination of cognitive behavioral therapy. Se llama terapia cognitivo-conductual. It was a new word for me. Combined with existential therapy. Why? We know that cognitive therapy works well with patients with anxiety. This has been proven also with cancer patients. But we felt many times, cognitive behavioral therapy, you think about cognitive errors, working on phobias. So Dr. Agalvez discovered yesterday that I have a phobia of spiders. It's not a rational fear. They're not very, they're pequeñita. They're not very dangerous, these spiders. There are no dangerous spiders in Canada, but I don't like them. It's irrational. But many of these patients, they have rational fears. There's a good chance the cancer will come back. It's possible. It's not irrational. So how do we help them with these realistic fears? They're afraid that their families are going to suffer. It's true. If the cancer comes back, their families are going to be upset. So for this, we added this existential component to talk about the specific fears. So what are your specific fears? Como I mentioned here, miedo a morir, a sufrir, a estar solo, sola, and also fears about what will happen to my family. Okay? So we thought it was important to combine both approaches. It's a group. We chose group because it's cheaper. It costs less money for me to see 8 patients at once than to see them one-on-one. It costs less money for my hospital to pay me to see 8 patients for 1 hour than for me to see 1 patient in an hour. So it's, ¿cómo se dice? Rentable. Okay? Cheaper. It's as efficacious, it works as well as one-on-one therapy. And what it does also is that the women sometimes they come and they say, oh, I don't know if I need help, but I would like to help other women. So it's what we call ayudar, okay? They're here to help others. And they like helping each other in a group, and they like learning from each other. ¿Cómo se llama? Aprendizaje vicario. Vicarious learning. It's one thing if I say it, but it's different when the other patients say it to her. Okay, it works better. So it's what we call a grupo cerrado. So that means once you start with your 6 or 8 patients, there are no new patients. Okay, sometimes you have groups where, okay, next week is someone new, and then no, this is the same women that meet for 2 hours every week for 6 weeks, and we have 2 therapists in the room. I was often a therapist in these studies. I like doing that. The fourth intervention is very structured. It's not just, okay, vamos a hablar del miedo a la recurrencia. No. We have exercises, we have a manual, and we have what we call deberes. ¿Tarea? Okay. Homework. Como la escuela, homework. Okay? They have to practice things during the week. Okay, this is just to show you that I study fear of cancer recurrence a lot. We have a lot of publications on FORT because we've been working on FORT for 12 years. We started with a small pilot study. Now we have done, as I mentioned, 2 randomized control trials. And I'm very happy to say we received money last week to do implementation study. So now we're going to take FORT and we're going to offer it in different countries, in different, provinces, 5 different hospital cancer centers, in small provinces, rural provinces, big centers. And we have 2 years for this, so we're very happy. Ok, vamos a hablar de nuestro modelo a la recurrencia, que es un poco complicado, okay? But I will try to explain it slowly. So this is how I explain it to patients. Okay, do not panic. All right, look here, this part. This is the conceptual model. This is the statistical model of this.
I think you have to.
Pointer? Oh, wonderful, okay. Let's see if it works. Oh, okay. Bueno. Theoretical model, statistical model. The statistical model was to justify, so we came first with this, and then we're like, maybe we need to check if it's true with some statistics. So we did this, we created the model first, and then we checked for it statistically in a publication 4 years ago. So in general, the model works. I will explain the model, 3 theories in this model, okay? Vamos. This is how I explain it to hundreds of patients, so you too can understand. I will do my best. All right. The first part is this in the middle. It comes from a British researcher called Leventhal. He did many models of illness, not just cancer. This model goes like this. First, the patient will encounter a trigger. ¿Cómo se dice trigger? Detonadores? Oh yes, that's the yes. Detonadores is because the boom, right? An explosion. Yes, it's what you said. So yes, gracias. So they will encounter one that's internal. So me duele la cabeza. Okay, I've got cancer. So they encounter a pain. That's what we call internal trigger, or external trigger. They go to the hospital, or maybe her sister now has cancer, or her neighbor has cancer, or she hears on the television about famous person has cancer, and now the patient thinks, oh no, I will also have a recurrence. Maybe she wasn't thinking about this, but now she just felt a trigger, and now she thinks, I will get a recurrence. I feel like maybe my cancer has come back. So now if you ask her, what do you think is the chance that cancer is coming back? She says 1,000%. Okay? She's convinced. Now she has this fear. She's sad, she's upset, she's sad, she might be crying. She has the fear. When you're upset and you're crying, you do something. It's what we call coping strategies that you would say. There we go. So you have to do something. What do those patients do? So they do these different coping strategies. One that is not included here is buscar informaciones sobre Google or con Google. Okay? I have many patients that spend 2 hours on Google a day. Okay? Looking for information. Have you ever been sick and looked for information on Google? Okay, me, yes. Oh. The information sometimes is bad, then worse, then very bad, and now I'm dying, okay? So this doesn't help them. It makes the fear here, in general, worse. Other things they can do is what we call body checking. That's just kind of, okay, what's happening? I had one man who told me, every day I do full from head to toe. I check every part of my body every day. This is not necessary and not recommended at all. Okay? And sometimes he would like touch so much, he's like, ow, it hurts. Of course, it's because you've been doing this for 15 minutes. Okay? So this is not good either. Okay, but why do patients do it? It's because it helps a bit. At first they're like, okay, there's nothing. But what about tomorrow? I have to do it again. Or they might be doing what we call reassurance seeking. So reassurance seeking means I'm going to talk to my husband and I will ask him, do you think the cancer is going to come back? Tell me, the cancer is not coming back. Or sometimes they will call their oncologist and they will ask, can I see you? I think there's something wrong. There's nothing wrong. But they ask, can I come and see you? Or sometimes they'll say, I know I'm supposed to get this test in 6 months, but can I have it like this week? And sometimes some oncologists say, okay, you're so anxious. Yes, we will give you this test. This is not good, okay? Because the patient feels okay now. Okay, phew. The test says I'm okay. But what about next week? Oh no, I need another test, all right? What we see the most in my patients and also in the 10 Mexican women we interviewed is avoidance, evitar, okay? What patients tell us is, I keep myself very busy. I work all day, I work in my house, I don't think. I never think about this. I don't want to think about it. So I avoid, evitar. What happens? You cannot always avoid. So what happens is that the fear comes back. So this is the first part here. There's a little part here that's another theory I will talk about now. Lack of knowledge. I've been talking about lack of medical knowledge a lot. It's important. Many of the patients I work with, also in Canada, they don't want to know. So I ask them, do you know what kind of cancer you have? No. Do you know what stage you have? No. Do you know what your risk is? No. Okay. Do you know what you should be looking for in your body? No. I didn't ask. Okay. So they don't really know what to look for. And when you don't know what to look for, you are more likely to think, oh no, my head hurts, I've got a headache. It means anything, it means the cancer has come back. This is a different theory. Que, I cannot say this in Spanish. Teoría de la incertidumbre. It's the most difficult word for me, uncertainty. It's an American nurse that created this theory. So uncertainty in general is difficult for all of us. But for patients, uncertainty about the illness or the treatments is difficult. And people feel like they're uncertain, their treatment or their illness is uncertainty when it's not clear, when it changes a lot, when it feels inconsistent, or random, or when they don't have information. This is why I keep talking about the importance of information. And when you have uncertainty, you don't know. It's like COVID. Remember COVID at the beginning? What is it? We don't know. How do we help? In Canada, everyone was washing everything everywhere because we didn't know. Okay? Everyone was panicking because there was so much uncertainty about COVID. It was very difficult. So uncertainty creates anxiety and reduces quality of life. For this reason and fourth, we try to reduce this uncertainty and to give them medical information. This is the second of three theories. The last theory is this part here. Okay? Intolerance of uncertainty and beliefs about it might be a good idea to worry. I will explain. So it's this part now we're talking about. And this model, it's cognitive models of worry. Modelos cognitivos de la preocupación. It sounds so nice in Spanish. Okay, so many patients I work with believe that if they worry, it's going to be helpful. So examples would be, if I don't worry about my health, maybe the cancer will come back and I wasn't aware. I need to worry. I need to be vigilant. I need to check my body every day. Okay? So they think it's better to worry. And they don't think about all the disadvantages of worrying. And also they have a difficulty tolerating uncertainty. So managing not knowing. It's difficult for many of my patients. And also we think, they worry a little bit and they really never think about, but what is my biggest worry? It's what I call evasión emocional. You worry, but you never think, what is the worst that could happen? So in fourth, we ask them, sit. Let's think, what is the worst for you? Okay? So we work a lot with these parts also. Now, I want to tell you, fourth, this therapy, this 6 weeks therapy has 6 objectives. So how am I doing with time? Are we okay? How much? Yep. Okay, so I have 6 big objectives: identificar, facilitar, distinguir, aumentar, promover, volver a examinar. So what do we want to identify? We want to identify those triggers and the coping strategies that are not good. We want to facilitate learning new coping strategies. So we teach them relaxation and cognitive restructuring. We want to help them distinguish between a physical symptom that is a good sign of a true sign that something is wrong versus a symptom that is benign. We want to make them better at tolerating uncertainty, aumentar. And it gets more difficult for them. At first, we're teaching you skills, relaxation exercise. That's easy, I like that. And then at the end, we do something more difficult. We ask them, so tell me, what's the worst fear that you have? We are now going to talk about specific fears. We're going to talk about, for example, fear of dying. This is the 5th objective. And the last objective is to talk about priorities. Have any of you worked with cancer patients before? Not yet, okay. A little bit, okay. Many cancer patients will tell you after cancer they feel different and their priorities about their lives have changed. Okay, they have new priorities now. Together with them, we're going to talk about what is their new priorities and also what is your future. Maybe you're not going to live till you're 80. It's possible you don't have as many years, but you still have a future. The problem with people with fear of recurrence sometimes is they tell me, I can't think about the future. So many patients I work with, we are now 23rd of November, Christmas is in 1 month. I will ask them, have you done any plans for Christmas? They'll say, no, I can't think about Christmas. What if I get cancer between now and Christmas? I can't think about Christmas. Or they tell me, I used to like to buy shoes, or I used to like to buy clothes. I don't do this anymore because the cancer might come back. So why do I need new shoes for, or new clothes? So they can't think at all about the future. We help them slowly, and I will give you an exercise for this. We help them slowly think about the future. So 6 objectives for 4. A little bit about assessment. So you meet the cancer patient for the first time. What kind of questions should you be asking? So same like you would with any patient, you want to know a little bit about the history. I usually start with medical history because it's easier to talk about for patients. They can tell you when they were diagnosed, how they were diagnosed, the treatments they had. Then I ask them, what was your reaction to the diagnosis? Usually they say, it was a shock. Okay? I ask them about en relación con el personal de la salud. The reason I ask them about that is often people with high fear of cancer recurrence, in my experience, there were problems. There were delays in getting diagnosed. Sometimes there was miscommunication. So what happens is they don't trust. They don't trust the medical system. They don't trust that they're going to take care of me well, because sometimes, even in Canada, we see so many problems. They lost my file. I didn't get the right test. They made a mistake. They didn't know. So there are problems, and then they don't trust. Okay, this increases their fear. And I ask them, what do you think your risk is? And when they are the people that tell me 100%, then I'm like, okay, now we have a problem. I will also ask them, do you have other illnesses? So sometimes I work with people that have 2 or 3 different medical illness. Past traumas. It's always important to ask about past traumas because that's going to make things a bit more complicated. Ask them, have you ever received a diagnosis of mental health problems in the past or right now? And social support. Who helps you? Who takes care of you? And then I finish by asking them about, tell me about your fear. What emotions do you have? What thoughts? What are your triggers? How often do you have this fear? At what intensity do you have this fear? What is the duration of the fear? How much does the fear bother you and bother your day-to-day life? y afrontamiento, coping strategy. What do you do with your fear? Okay, I'm looking for good coping and these bad coping strategies we mentioned, so I know, okay, I need to help her with these kinds of strategies. And now I want to give you 5 possible ways, okay? I want you to have 5 practical ways of helping a cancer patient in your work, and your future work as psychologist, because there are so many cancer patients, you will probably meet someone with cancer during your work. So 5 interventions. So first one is identify those triggers. I don't even want to say that in Spanish. It looks like I'm going to make a mistake. So identify triggers. Everybody has different triggers. Most patients, body sensations is almost always a trigger. So I asked each woman, tell me about your trigger. And in the group, we asked each woman, what is your trigger, your trigger, your trigger? Okay? And then we asked them, what do you tell yourself when you have a trigger? What goes through your mind? So we start identifying their thoughts around this. And then we try to identify not just the thoughts, but also what happens in your body. Oh, I get hot. I'm hurting here. I feel very anxious. I'm shaking. What do you do? Oh, I go home and I just stay alone in my room and I don't talk to anyone. Okay, so now we know, okay, your emotions, your thoughts, physical sensation. This is, the cognitive behavioral therapy circle where you look at all the parts. So we do that with them. Why? Because we want to make it more predictable. At first, patients come and they're like, I'm scared all the time. I don't know what to do. And then we start saying, but no, you're not scared all the time. Look, you're scared when you come to the hospital. You know when you come, it's going to be difficult. You're going to feel sad. For at least 1 week, you're going to feel scared. You will do this. It becomes more predictable. Then patients feel like, oh, I can manage. I have control because I know what I have to look for. We do cognitive behavioral therapy. Is this something you've seen in some of your courses, how to look at thoughts? No? Okay, so this is really the basic of cognitive behavioral therapy. We help people to identify, okay, so you had a trigger. What was the situation? Okay, medical appointment. Tell me your emotion. Anxiety, 90%. Okay? 90%. Because we asked them, what is your emotion before you start thinking? And they're like, I'm so anxious, 90%. What was what we call automatic thought? What went through your mind? And the patient might say, no puedo hacer esto. If el cáncer se regrese, no puedo hacer esto. No soy suficientemente fuerte. I can't do this, okay? They panic. And then we ask them, okay, so tell me, what are the facts? How do you know this? So this is very cognitive behavioral therapy. And then we ask them all, this is a skill we teach them, come up with a more realistic response. Or sometimes a thought that helps you more. And then they come up with something, this is the example we give them. Puede ser difícil, pero puedo hacerlo. Okay, I will manage. There's no evidence that the cancer is here. And then we ask them, okay, now you think a little differently. What happens to this anxiety? It decreases. Now maybe my anxiety is only 30%. So this, what we call cognitive restructuring, is something we do with any problem in cognitive behavioral therapy. It's kind of the basic of what is your thought and how can you answer back your bad thoughts. You've all been anxious, I'm sure, and many things happen. We teach them how you talk to yourself, something that's more helpful. We give them an example, then we ask, okay, your turn. Your turn now to come up with a recent moment when you had the fear. What went through your mind? And you do all the steps together. Here's another explanation of this, of this cognitive restructuring. Okay, what is the trigger? What is the thought? Okay, estoy seguro de que mi cáncer volverá también. What happens here for you in terms of emotions and behaviors? And I guess this you may not have seen. We call that thinking error. And then there's many thinking errors. We all have thinking errors. Pensamiento en blanco y negro. We say that like this? Okay, yes. So now you're only thinking of the worst. Or we say that catastrophizar. Okay. That's another. So we help them think about their thoughts and just realize, okay, sometimes maybe your thoughts are not helpful to you. So helping patients realize what they're thinking and what their triggers are is the first thing you can help them with. The second one is coming up with questions with healthcare providers. So I told you, many patients, they don't know about cancer, they don't know about what they can do to prevent it. They need to get more information. You can help them come up with 2 or 3 questions, good questions that they can ask to get more information. This will reduce the uncertainty that they have. Okay? You can also help them learn to tolerate uncertainty better. Okay? As I told you, many patients think, oh, this helps me. Worrying helps me. But it doesn't just help me. There are disadvantages. Have you ever worried? And you know that worrying is very tiring. You spend so much time worrying. It's difficult. It's very difficult to worry all the time. So we help them think, what are disadvantages? But we know these patients, they don't want to stop worrying completely. And it's not good to never worry. We want what is called here, una curva en forma de U invertida. I will show you. We want them to achieve an okay amount of worry. And this is different for each person. This is the U curve, okay? The way I teach it to patients is like this. You have an exam next week, okay? Are you worried about your exam? Or you have one tomorrow. Are you worried about your exam, okay? The answer is probably yes. If the answer is no, sometimes you're a bit like one of my sons. He's like, oh, it's okay, Mama. I'll be fine. I don't need to. Okay. Okay, and what was your grade? Oh, not very good. Not very preoccupied, not very worried. You don't study. We say performance here, or you can imagine like a grade. Not good, okay? But sometimes you study and you become so worried and so anxious that your performance here is bad. Has this ever happened to you in an exam where you took the exam and you panicked? It happened to me once in my life, only once, in a statistics exam, in a math exam. I started panicking and I was talking to myself, oh, no. And my friend was like, shh, stop, you're bothering everyone around you. And 10 minutes went by like this. Página blanca. I couldn't think of anything. And then I said, okay, change page. And then I started writing. But I panicked. So my performance was very bad. I was too anxious. What we want is anxious, enough. Good anxiety, good performance. I studied, but I'm not panicking. It's the same with the patients. We want you to be worried, but not panicking. Okay? So this sometimes helps patients realize, okay, I don't have to be here. Maybe I can worry a little less. Okay? This is the third, and then maybe I need to hurry, yeah? All right. Something important is to help them, you can read, help them get into their worst fear. So they think about the cancer, but they don't really stop to think. We are going to ask them now to really think with vivid image about what it means for them when the cancer comes back. It's what we call exposure. Exposition, you know this from some of your course. You know, you're scared of something and you need to expose yourself. So what we're going to do is we're going to ask them to write down some of their fears, and then we're going to ask them to write a movie script. Okay? A movie script where they're going to talk about the fear in details. This is very difficult for the patients, but we tell them next week, I will help you come up with a movie script that is not as bad. And then we finish with a relaxation exercise. So all to say, what I want you to do is to get your patients to talk. They will do a lot of avoidance with you. Oh, I don't want to talk about this. Okay, take our time. Let's talk a little bit. Tell me more about why this is scary for you. Okay? And then we're going to ask them, okay, what can you do to feel better? What can you do to change this worst case scenario? What can you do to think differently? And there are some questions here about, well, how can you think about this worst case scenario? There are things you can do. Sometimes you think, oh, there's nothing I can do. But no, you can think, you can talk, you can do something to resolve your problem. And so this is the fourth strategy. The last one I want to talk about, one that I like a lot, is tell me your values of change. What are your important values? Are there parts of, I'll say this in Spanish, hay personas, sentimientos o aspectos importantes de ti mismo, elementos de tu vida que has dejado en suspenso desde que te diagnosticaron el cáncer? Maybe there are things you don't do anymore. What are the things that are important to you that you want to include back in your life? Tell me about your values. What is important to you? Tell me about the future. What does it mean to you? What do you want to do? And sometimes they're like, oh, I can't think about next year. Okay, tell me what you want to do tomorrow. And then, okay, you can do that. Tell me what you want to do next week. And then tell me what you want to do for Christmas. And then tell me what you want to do after that. So slowly we tell them to write down what you want to do this week, what you want to do next week, next month, so that they're not so scared. Okay. Gracias por su atención. And now we have time for questions in Spanish or in English. Gracias. If not, you will have to ask me a question. No, a question.
Considerando que la espiritualidad en las poblaciones marginadas puede ser en realidad una herramienta muy útil de afrontamiento, sería interesante que a la hora de implementar o en este estudio implementario se trabajara también sobre la parte de espiritualidad, porque se puede llevar a regiones no necesariamente en las ciudades con altos índices de escolaridad, todo lo que tiene que ver con esta parte en donde aumenta el índice de espiritualidad.
Yes, we are. So one of the things we are doing, it's a very long process to adapt the intervention. One of the things we said we need to do, so our manual has examples, okay? And the patient also, they have this manual with examples. We changed the examples to talk more about spirituality. Because here people talk about their spirituality. In Canada, we don't. So we don't have any examples with spirituality, but we change some of the, and we said, good coping strategy, spirituality. So this is not something we do in Canada, but we changed it here for Mexican context, that we talk about this in the group. So we included that.
Podría ser también una estrategia implementada en Canadá, entendiendo que probablemente el contexto es diferente, pero que la base de la estrategia puede ser funcional para cualquier persona, no necesariamente dependiente de la cultura.
Yes, I agree. I think in general, it's a good strategy. The patients I have that have these spiritual beliefs, it helps them. It's just, for us, it's considered so private that I wait in the group for one patient to bring it up, and then we say, hey, what do others think? So that's the biggest cultural difference. We can't really ask you, hey, what is your religion? We have to wait for you to say, you know, I'm praying and helps, and then we say, oh, okay, good, tell me more. So that's the little difference, but here in Mexico, we will say, okay, let's talk about religion and how religion helps us. So that's a big difference. Yes, por favor.
I have two questions.
Yes.
General commentary.
Okay.
Mi primer comentario es que me gustó la presentación
Muchas
sistemática.
gracias.
Yo no trabajo así. Me gustó el interés en buscar procedimientos que sean costeables, baratos. 6 sesiones para 6 personas es barato para ustedes. Yo trabajo con 65 personas una vez al mes. ¿Sí? Entonces, todavía tengo que reducirlo más para que lo paguen. Bueno, mi primera pregunta es, ¿cómo se evalúa el impacto del CORT de las 6 sesiones? ¿Es una evaluación individual o una evaluación grupal?
Both.
¿Sí?
Los dos.
Y si esto es solamente con autorreporte o se utilizan otros procedimientos de evaluación.
We have interviews also with some women, so we have auto questionnaires, and also we have interviews where we ask them, so how was this helpful for you? So we do both interviews to know more about the details, and also, yes, questionnaires after, and then 3 months and sometimes 6 months later.
Mostly self-report.
Self-report, yes, self-report, with the limitations of self-report.
How about psychophysiological?
We don't do a lot of that in Canada. Yeah, the truth is it's very few places now do that.
In my experience, many cancer survivors don't have enough skills, maybe cognitive skills to be able to advance about, for example, the reconstruction of her.
Yes, that's one of the things we are going to see. Can they do it? Yes, I agree with you. Some patients don't like cognitive restructuring, thinking about their thoughts, but they like doing the relaxation exercises. They like talking with other women. So we have different strategies that we teach them. So sometimes I tell them, okay, you don't like this, that's fine. But look, I've got 10 other things I can show you. So maybe in here, there are some that will work for you, but not for her. It's okay. And I want to say something about the costs. So yes, it's a little cheap, but not very cheap. So now there are many investigations around the world to do internet, totally online, so that it's cheaper, or to have maybe one session or just information. So we're trying to find interventions that are even cheaper, because it still costs money to have 2 psychologists for 6 or 8 patients. So we are looking for ways to make it more accessible and cheaper.
My second question is about the assessment role, and we found that some people don't need psychological support.
Yes.
And without assessment, it's impossible to identify which of them need of our help and which of them don't need even
Yes.
to lose time with the psychologist.
It's
How do you do that?
It's a big problem, I think, for us also in Canada. Every cancer patient, every time they come to the cancer center, have to fill a form. What is your list of problems? Yes, no, no. Do you want help? Yes, no, no. And we are supposed to help, offer them. Then we say, okay, well, you said yes. Do you want to see a psychologist? No, gracias. Okay, so it is a problem for us also. It's hard to identify the right people. Many people say no, they don't want. So sometimes we think maybe it's best if it's offered outside of hospital, but it's always a challenge for us. We have instruments, but they're not perfect to identify people who want to see a psychologist. And some people want to see a psychologist, but we never tell them that we exist. So they find us, they're like, oh, no one told me that this existed here. I wish I had known that 1 year ago. So there's a lack of communication, to put the right the right patients with the right treatments. Even though we have treatments, it's not always a good match. It's a real problem. Thank you. Yes? Yes, it's important because when patients come to see me, I know that it's their last choice, right? Most people are like, oh no, it's the first time they see a psychologist, and they're like, Doctora Sophie, am I crazy? They feel the stigma. Not everyone, maybe not the younger ones who are looking for a psychologist, but we do a lot of public education around mental health, how mental health is important, to destigmatize. But even our psychology students, so students like you that are at the level of the doctorate, they feel really bad when they need help. So one of the things I do, I teach our students first year of postgraduate studies. First day, I'm their first class. And I tell them, I've been to see a psychologist twice, and I've had 2 psychologists that have helped me with important things. And I had like 6 months and another 6 months. So I've been in therapy myself. I tell them, they're like, it helps them because they also, even though they're psychologists soon, they feel like, oh no, I should not have any mental health problems. So there's a lot of work that we need to do with students, with also other healthcare professionals like oncologists. We exist, we are important. It's not bad to go see a psychologist. You know, mental health, it's something that happens. So I try to normalize, and I ask oncologists to also normalize. Okay, we can help you with this. You're suffering, we have resources for you. It's an important thing for us also. We're trying. It's not perfect. Yes.
Algo que me pasó a mí en Querétaro, sí, definitivamente diferente de lo que era en México, es que había un programa del gobierno que les daba dinero a las personas en las zonas rurales, y entonces les decía, ok, te vamos a dar dinero, pero para que recibas el dinero tienes que ser revisado por el nutriólogo, el médico general, y eran como caravanas que iban a estos lugares. Y uno de los profesionales que visitaban era el psicólogo. Lo supe porque cuando les preguntaba a los pacientes que venían de zonas rurales, ¿tú sabes qué hace un psicólogo? Me decían, sí. Y sabían perfectamente qué hacían porque el gobierno les había llevado, ¿no?, a fuerza, digamos, porque tenían que ir con él forzosamente para que recibieran el apoyo. Progresa, ¿era? No me acuerdo. Era un programa social de la Secretaría de...
Wonderful.
Sí. Era fuerza, pero al final como que funcionó, porque cuando llegaban conmigo al hospital, ellos lo habían buscado y sabían a qué se referían, ¿no? Entonces tal vez es una manera cultural de hacerlo, como te lo acerco a través de algo que tú quieres, que tú sientes que es como una recompensa para ti, en el sentido de que ellos querían el dinero. Y a largo plazo funcionó porque sí sabían, de verdad tenían una idea muy clara de qué estaban buscando, y para que me sorprendió muchísimo. Todas las personas que habían recibido ese apoyo del gobierno sabían que hacía un nutriólogo, psicólogo, dentista, o sea, médico. Había funcionado muy bien. Entonces,
Wonderful, yeah.
Sí, a lo mejor es distinto, ¿no?
Yes.
Lo tienes que llevar y los obligas, ¿no? Lo asocias con la recompensa que están buscando y al final funcionó, ¿no? Entonces,
ahí se lograron enganchar, o sea, quitándoles tal vez como ese uso monetario.
No es para amplificar,
Es que
es
eso es
para
la...
Ok. Ahí pregunta, en el estudio no les quitaron como ese apoyo monetario para ver si se engancharon con el tratamiento.
Ya no recibían el apoyo.
Okay.
O sea, cuando iban conmigo no recibían el apoyo por ir conmigo, digamos. Ajá. Entonces podríamos pensar que fue una manera de generalizar el apoyo, porque sí lo buscaron y ya no les daban dinero por ir a verme, digamos, ¿no? Y creo que es una buena manera de ver cómo funcionamos nosotros, ¿no? Al final, o sea, a lo mejor ellos funcionan con folletos, ¿no? O páginas de internet,
Yes.
¿no? Y probablemente nosotros, bueno, a lo mejor hemos cambiado, ¿no? Después del COVID, somos otras personas, y a lo mejor otras herramientas podrían funcionar. Pero al final, aunque sea una política, si no la acercamos a la población, pues no va a funcionar, ¿no?
Interesting. That's very interesting.
Y la segunda parte era si se ha notado diferencialmente alguna dificultad en alguno de estos pasos. Por ejemplo, que a las personas les sea más difícil explorar por qué de sus miedos, porque la identificación de los triggers pues es como un poco más sencilla.
Yes.
¿No?
Absolutely.
Pero a medida que vamos avanzando, tal vez hay algunos pasos, hay algún factor relativamente más difícil que a los pacientes se les haga.
Yes, absolutely. That's why empezamos con la parte más fácil. The triggers, okay, relaxation, no, okay, that's okay. And then, slowly, we do things that are more difficult. Looking at the worst fear, this part you mentioned, that is the most difficult. Every patient is crying. The therapist and I were like, okay, this is the most difficult part because we know that they're suffering a lot, but that this will be helpful. It's like when you have a phobia. You have to face your fear to get better. There is no other there is no other way. You eventually have to think about what you're scared about. It is very difficult, but we're here. I am like, okay, you'll be okay. We can do this together. And then they realize, oh, okay. Many patients, they have come back to me the next week. And Lisa, maybe you can translate this, but some wonderful examples is patients who are like, oh, there's nothing I can do. Then they come back next week and they're like, I talked with my daughters. I had this wonderful talk and now I feel like, okay, it's better. I talked with my husband. Or they said, finally, I made mi testamento. Okay, I was avoiding doing it, but now I feel better. So this forces them to do something. So they don't just stay there, they have action now. They do something. But I agree, it is the most difficult part for them and for me, because I know I'm asking them to do something very difficult. We've done interviews, the question about how do you measure this? We've done interviews and we asked them, what was the best strategy, the thing that helped you the most? They're like, it was doing this movie script, the peor miedo, that was the most difficult, but what has helped me the most. After that, I feel lighter. This helped me the most, but it's difficult. So we do it at the end. Okay.
Muchas gracias.
Oh, de nada. Un placer.
A la doctora le gusta tomarse fotos con su público.
Oh, gosh. You like photos.
No,